Okay, now, signs and symptoms of dysfunction. If your left ventricle isn't working properly, then what kind of issues is your patient coming in with, please? Pulmonary. What does that mean? Pulmonary edema, orthopnea. What does that mean? Hey, doc, when I go to bed, I have this beautiful, beautiful bed that I bought. Nice foam bed, and, it's fantastic, but I never get a chance to use it. And whenever that I do at night, I feel like I can't breathe. So I have to place 4 pillows underneath my bed. Now, at this point, I have to sleep in my recliner. Can't even use my bed. You know how bad I feel? Welcome to orthopnea. Or, hey, doc, I sleep at night and I can't breathe. I have to run out to the window, open it, and I have to take a breath of air. This is PND, paroxysmal nocturnal dyspnea. This then to you signifies failure of what side of the heart? Left side of the heart. Back up into lungs. Welcome to transudate pulmonary edema. Worst case scenario, you have blood that is now escaping into the lung and parenchyma. These are called heart failure cells or hemosiderin-laden macrophages. All the macrophages do is they come in and they're going to gobble, gobble, gobble anything that's in that particular environment. Maybe it's coal. Well, later on we talk about coal workers' pneumoconiosis. Those macrophages will gobble up coal. And here, it's blood and hemosiderin. So different places in which macrophages. Atherosclerosis. Forgot about that one, huh? Almost. Macrophages come in and they gobble up LDL or cholesterol. Welcome to foam cells, right? So in general, just understand the concept. What if it's right ventricular dysfunction? Now we get into circulatory issues on the systemic side. So we have positive JVD. You might have pitting edema. Now, before we get into anything further, it is important that you pay attention to the official New York Heart Association classification. Now, class 1, symptoms only with maximal exertion. So we're in the process of congestive heart failure, but we're going through different classes. And in your mind, you might want to bring that graph that we just reviewed in great detail to then help you explain the different classes. So imagine now you're moving clockwise. Why did that performance decrease? Because of decreased contractility. At some point, the contractility may then be improved. Well, not so much a contractility, but the performance might be improved because of an increase in volume due to compensation. We talked about aldosterone. Symptoms with moderate exertion, class 2, moderate. Minimal. Now we're getting worse, huh? Even minimal exertion is then going to exacerbate the issues of heart failure. And then symptoms of rest. If I were you, I'd pay attention to class 3 and class 4. Ladies and gentlemen, the parallel that I wish to bring here as well is that there will be particular WHO classifications that is imperative for you to keep in mind when dealing with what's known as pulmonary arterial hypertension. And the reason I say that is because when it comes to pharmacology and management, they will then ask, and all they put in there is, well, your patient has congestive heart failure showing symptoms of class 3 and class 4. Or, hey, I have a patient and the patient is now exhibiting symptoms of class 2, class 3 of pulmonary arterial hypertension. So it is important that you pay attention to some of these guidelines. They're created on purpose, and you must understand the clinical significance of it. You begin here with NYHA.